Okay, good afternoon, everyone. It's wonderful to see that there are so many people on the virtual town hall. So that tells me a couple of things. That people want information and that also people are engaged and want to move the organization forward. I truly appreciate you joining our virtual town hall. So the intent today is to provide, as we have 2 weeks ago or a week ago, information about COVID, uh, talk about some hot topics that are out there, and to also respond to any questions that you might have as it relates to some of the guidance that has changed so quickly. Um, Thank you very much. So I want to start out with a couple of things. You know, I shared this with morning meeting. Any of you who are on morning meeting, and I apologize for those of you who were to hear it again. But you know, driving home last evening, uh, you know, I was struggling, not in a bad way, but struggling as to how do I get my arms around everything that as a leader and as a director that I want to provide for the staff and my colleagues and the leadership team here. I was struggling. Am I giving them enough? Am I not giving? Am I giving too much? Am I asking too much of them? And you know, I have about an hour and, depending on traffic, an hour and 15 minutes, an hour and a half drive. And so it really gave me an opportunity to focus on myself and to realize that there are so many things that are going on right now, so many challenges, and I myself feel the pressure. And I myself feel as though I'm asking so much of every employee, and it is turning people's lives around. It is changing. And I wanted to know, how can I influence, or how could I ensure that Albany, Stratton, uh, continues to provide the care they had? So struggling with this issue, I was feeling a little discouraged and saying to myself, it's so hard to come to work every day. It's hard to know that the lab is doing a number of tests every day and with a decreased staff. It's a challenge to know that, you know, I've had to make some decisions with others that may have influenced personal time. Then I took an opportunity to say, well, why are we doing all this? Well, we know that this is a different surge. We know that this surge is not just about taking COVID. And if you remember, our very first COVID patient, people were standing around applauding us. They were thanking us. They were sending us free food. We felt as though we were part of the community. And I thought, well, perhaps people are feeling as though they're not getting that recognition. They're not getting recognized for the things that they're doing. And my thought was, no, it's not about recognition. And finally, by the time I got to probably exit 13, I realized why I'm doing all of this and why I know that the executive team is with me 24/7, and why when I call them or text them in the wee hours of the morning, they're responding to me, or any of the supervisors, or when the AOD calls me and we have a conversation of things that may be going a little difficult in the ED. That people do this because of the mission. I was brought back. That's why I do this. I'm reminded of what the mission is. So I know that all of you have experienced different levels, some directly if you're doing direct patient care. And I feel for you, I understand, but I'm reminded of the mission that we have. I'm asking a lot of every employee, and I know that there are some who say, well, I could say I won't do this, and that's the choice that you have in terms of speaking with your supervisor, or you can question it, or you could say why. That's what we need to do, is have forums like this, We could have discussions so that you understand what's going on. So, you know, I was thinking again of what can we do for employees. A couple of things that I did today is that I asked that we focus in when we're doing employee engagement on burnout. What can we do for burnout? Because I recognize it. I see it in the face of many employees as I walk around and talk to people. I see it in the faces of the executive team. And what can we do to do that? And I'm not going to give up. I'm not going to say we've already done that. I'm not going to say they've seen that already. I'm going to continue that effort. I'm going to continue the effort of having forums like this so we can ask questions, that people can come up with other ideas, and we can move forward. I'm going to continue the efforts of looking at our salaries in terms of pay scales. Are we doing what we can for the organization? Are we doing what's right? How do we compete with the community? We start off slow and we'll move forward. And I'm going to continue to lead the way that I know how to lead, and that is not from behind, but in front, so that I can be a good role model for all of you. You know, and I'm reminded that you'll forget what I say, you'll forget what I do, but you'll remember how I make you feel. And so our intent today is to make you feel valued. Our intent today is to give you an understanding of where we need to be as an organization. My intent today is to say again, and I know you don't perhaps want to hear this, but I have a heartfelt thank you. For everything that you do every day. So no, we don't have the community driving around beeping the horns. We don't have them outside our windows clapping hands. But know that I'm in the forefront along with my leadership team, thanking you and rolling up their sleeves and doing what they can to support you. So I sometimes go on and on and on. I apologize. I know my strengths and I know my weaknesses. So we're going to move on you're going to hear from different members of the executive team. You're going to hear from people on the incident command team, and then we're going to allow, you know, for questions and answers, and we'll move on from there. Okay. Situational report. Again, let's give you, I think I'm doing this. We did practice, but currently we have 8 COVID positive patients in-house. We have 86 veterans we are monitoring in the community, and I did talk to someone in the ED just a little while ago, and they did tell me that the ED was quite busy right now with possible COVID patients, and that's what our day is on daily. Bed occupancy right now in our ICU is 4, 7B is 14, 8B is 19, 9B and 9C at 21, 10B and 10C, we have 10 in mental health and 6 in the SARP. So you can see that we fluctuate from day to day. We look at this morning, noon, and evening. Amy is on top of it with her team. And her associate chiefs, and they know exactly who is in house, what are they doing, and when are they discharged. Our COVID-19 vaccine clinics still exist on the 3rd floor, and we work with supervisors to schedule any appointments that may be needed or people can stop up. At the close of business, again, as of January 12th, we've given over 30,000 vaccines. Unbelievable, the work that's being done. We will have an update for you in terms of the facility, what's going on in the facility, what's going on in the VISN. We're going to talk about moving forward, and Dr. Howard's going to give a little bit of an update on the community call. This information is shared with you, I think, daily, and if you need more information, we'll be happy to give that. So the next slide. Hot topics. I'm going to ask the Associate Director to present this slide, and then others could add in if needed.
So good afternoon, everybody. Thank you for joining us in the town hall. Before I get started, I'd like to echo what our director was saying. We recognize everybody's really continues to do an outstanding job throughout the pandemic. It's not over until it's over. So we do recognize that it's not easy coming to this facility to do what we ask you to do day in and day out for the past going on 3 years now. So from my chair, I'll thank you all for the effort and for the hard work you guys putting in. Hot topics. So in hot topics, we wanted to make sure, because the Omicron variant seems to be a little more agile than the previous two variants, that to protect the facilities and to protect our staff and the veterans coming into the facility, we wanted to make some changes and adapt some guidelines as far as what type of mask and how we would like to see everybody masking when they come into the facility. So veterans and visitors coming into the facility, we're going to be asking them to use the medical procedure mask. We know that does works, and that does mitigate or have a better mitigation factor in the prevention of transmitting the virus amongst from person to person. So that started this week. We position the entrance of the facility and throughout the facility messaging, and we continue to engage community with messaging. In fact, we have our public officer ready to engage again so we can send the right and appropriate message to our community, and everybody understand what it is that we're trying to do. Our VA employees, as you know, we are regulated by different policies. Our policies come from the VA, VHA, and we all know what's the expectation if you're a VA employee in this facility. So the change in masking procedure was geared towards visitors and veterans coming into the facility to prevent them from coming in with gaiters, handkerchiefs, cloth masks of any kind, and we're trying to prevent that from happening, and trying to steer them to start wearing medical procedure masks or respirators if they have them. The intent is just to continue to build that guard of protection amongst all of us. There's nothing else behind that. We just want to make sure that we combat the virus as we've been doing for the past 2.5 years. So this is just another tool in a toolbox, and we just decided amongst ourselves in the facility through leadership and reading everything and understanding everything that we know about the virus to execute that. Our incident command group is reviewing guidance received today regarding the uses of offering N95s, masks for non-clinical staff. So it's a memo that came out today. We are reviewing it and trying to get a good understanding before we put out guidance to the rest of the facility. And that has to do because there's a mandate for clinical staff to wear N95 masks, and that is a fitted mask, opposed surgical masks for the rest of us. So it might be an opportunity now for the rest of us, if we feel the need, because it's going to be, as I understand it so far, it's going to be on a voluntary basis. If we feel the need that we need that extra layer of protection, then we can go and request an N95 mask, and one will be afforded to us. So more to follow on that. And if we can get back to my hot topics, I know what I have to say next. There we go. Thank you, sir.
Somebody accidentally shared your screen. I'm bringing it back up.
Okay. I don't know. I'm trying to follow the chat also to see if there's any questions so far. None so far. Great.
No, Chino, I'll check the chat for you. You guys can just keep on going.
All right. Thank you. Then I invited our HR partners. I don't know if Michael and his group are here with us. And Michael, if you can take over the next two bullets there. There's extension and postponement of annual leave when necessary to ensure adequate workforce. And we'll talk about that in a minute with HRs and our partners and whoever he invited to the town hall. And the last one is a minor change of operations. It's only going to affect when we come in in the mornings and when we leave in the evenings. The new employee entrance, northwest entrance that we established a couple of years now, about 18 months ago, was meant to curb traffic, foot traffic coming into the facility and separate, for the most part, our staff and everybody else coming into the building. Again, with this new variant, we want to make sure that our staff receive the top layer of protection, because we're the ones that have to take care of the ill. And we want to make sure that we have healthy employees to do that to the best of our ability. To that end, we have some discussions with the leadership, and it was decided to allow traffic to come into the facility and leave the facility at the northwest entrance. So we will like everybody to effective immediately, started on Tuesday. I think my team is telling me Tuesday is when we're going to be ready for that. To come into the northwest entrance and leave through the northwest entrance. Okay, we will position, we will continue to use the front entrance for all those individuals who were handed a placard or have a handicap placard or some sort of disability placard that went through the police. And if you can all recall, that was established early on during COVID when we opened the northwest entrance. So those individuals can continue to use the front entrance, the main entrance of the facility closest to where they're parked. Everybody else, I will appreciate if we steer all that traffic during morning rush hour and during the evening rush hours to the northwest entrance. That is not to say that you cannot use at all the front entrance. We recognize that throughout the day you might have business to tend to, picking up lunch or wanting to go out to lunch. You can continue to use the front entrance, and we'll encourage you to follow the flow of traffic, which is coming into, if you are inside the building, from the right-hand side of the building and leaving at the left-hand side of the building. If you are looking at the building from the outside, coming from the left-hand side of the building and exiting the building on the right-hand side. That is important so we can mitigate the spread of disease. In the first 30 days, I'm going to have, and I have asked our police department to help us in ensuring that the new changes are being observed. I think the night shift has their cards, their PIV cards already coded, so they will continue to use the main entrance after 6 o'clock. So there's no changes there. The northwest entrance will be open from 6 to 6, and they can be used to enter the building and exit the building for all our employees. Team, did I miss anything? Because I know that's the big one here for changing traffic and how we do things.
No.
That's correct. I'm reading some of the comments here, and Dr. Raptors, that's correct. After hours, the front entrance only. And that's also correct. Anybody coming before 6, you come to the front.
Okay.
So
thank
that
you,
was my
Tim.
piece,
Yep,
team.
Thank you.
Before I get into this, did we want to talk about leave, or is Michael going to talk about that later?
Michael, are you on the call?
Yeah, I can answer the question that popped in. So right now there is no COVID leave like there was last year. They had the emergency paid leave signed into law for us to use at the end of last fiscal year. Our only option right now, the director has authority to approve weather and safety leave in certain circumstances, not all circumstances. So it's not as broad as the COVID leave last year. So essentially, if there is an employee that is placed out of work due to the agency testing and is not in a telework eligible position and are not incapacitated, she can approve weather and safety leave for those individuals. If you are in a telework eligible position, the expectation is that you telework if you're able to. If you're unable to due to symptoms or otherwise incapacitated, you're expected to use your own leave.
I think, just to add on, I think the bullet was, I mean, that's really great information too, but I think the bullet was in reference to Incident Command's decision to extend the postponement of leave for staff when it's absolutely necessary until the 31st of January. And then that again is due to the continued rise in the community spread of COVID and also the positivity rate amongst our staff. And Michael, there was also new guidance that came out about workers' comp and COVID. So maybe at some point soon we can share some more information with our managers, supervisors, and staff on that as well.
I don't know if there's a bullet point for that in the presentation, but I did invite one of the workers' comp specialists that supports our facility from the Vision workers' comp program. And I do believe I saw him on the call. So if I don't want to spoil the surprise if there's another slide for that. If not, I can ask.
I don't think there was this. Yeah, I don't think there was a separate slide for that. But if anybody has questions, there is somebody available to answer.
Is it possible for me to go ahead and just kind of read through the latest and greatest when it comes to this? This is Jim Lass. I'm the workers' comp specialist for Albany.
Hi, Jim. Yeah, I guess the highlights would be good for the changes.
Okay,
Thanks,
I think
Jim.
what it's going to do is actually, you know, it may answer some of these questions and maybe probably cause some questions to pop up. And again, I have my supervisor Kathleen is on, and I'm sure she could answer a lot of the questions if they come into the chat. But let's hit who is a covered employee. A covered employee means an individual who is employed by federal service, and then they have give you a little defined under section, et cetera, et cetera. Been diagnosed with a COVID-19 during his or her employment, whose duties require contact with patients, members of the public, or coworkers, or include a risk of exposure. So I'll hit that a little bit later, but it's you know, it's not something you get at home and you would be able to do a case for. Now, covered exposures. Covered exposure, the interaction does not have to be direct physical contact or for a specified time. General office contact interaction is sufficient. This includes shared workspaces like lunchrooms, break areas, and common restrooms. So if you had an employee who ended up being COVID positive and you were with them in the break room and you end up getting COVID, that's reason for you to be able to do this. And then also the other covered exposure is COVID-19 symptoms or positive test results within 21 days of that covered exposure. It just means you were with that employee in the break room, and then you catch COVID within those 21 days, Department of Labor saying that is the exposure period, and you would be able to put in a comp case. Now, if a claim is submitted, it will be as a COVID-19 CA1. They don't treat this as an occupational illness, Department of Labor. And just to reiterate, Department of Labor, this is their process. They own everything. They own everything, including any files, any medical, all that stuff that comes to them for the claim. So they are the be-all, end-all. We just facilitate it and try to make it, you know, the process easier for our employees and make sure that we're doing it correctly. Please utilize the eComp brochure contained within the postmaster message for the process that went out yesterday. Now, we'll talk about really quickly establishing a diagnosis. They have the thing called the polymerase, I'm probably not pronouncing correctly, chain reaction. They call it PCR COVID test, or positive antibody or antigen COVID-19 test. Or if there's neither of those, if you have a COVID-19 diagnosis that can be put together by a physician, their provider, and have a rationalized medical opinion. And I will tell you, that's what Department of Labor loves to see, rationalized medical opinion, supporting the diagnosis. The explanation as to why the positive test resulted is not because why didn't we have a positive test? That's what the doctor's letting them know. Now, I will say this, home tests are not acceptable by the Department of Labor for workers' comp purposes.
Jim, I'm just going to pop in just for a minute.
Sure.
Yesterday's postmaster had a different establishing diagnosis. We received new guidance yesterday afternoon, in the evening rather, after this postmaster was sent out. And it actually makes it a little bit easier because a positive antigen or antibody test result no longer needs to be accompanied by documentation. So they've broadened the acceptance. So that there'll be an amendment to that coming out this afternoon, hopefully. But that new guidance, as it's changing minute by minute, came out yes, in the evening, and we'll update that. Go ahead. I'm sorry, Jen.
No worries. Thank you. All this being said, the decision to submit a claim lies within the hands of each employee. Workers' comp team for the VISN, me included, of course, will process each submitted claim and are available for assistance or questions regarding the process. And finally, we are not the adjudicators of the claim. This is a Department of Labor-owned process. As I said before, they are the final adjudicator. Should, for some reason, they deny a claim, they're always going to provide appeals due process rights and documentation with that denial letter. And that just kind of hits it really quick. I'm sure there's going to be questions, and I am available should anyone have questions. And I will give it back to you folks.
Thank you, Jim. We appreciate you being on the call and able to give our staff the update that's needed.
You're welcome.
All right, so the next, I think on the docket right now is Dr. Howard, who's going to talk a little bit about the potential hospitalizations.
Yeah, thank you. As you all know, I think from previous calls, that the consortium of hospitals in the Capital District and the surrounding area has a group call every Monday and Thursday morning, which the VA attends and contributes to. And we follow the trends in the community in terms of hospitalizations, deaths, and ICU care pretty closely. Those calls in recent weeks have shown a considerable spike in number of hospitalized patients, although in the last week it's only gone up about 3%. And like all of those hospitals, or those hospitals are all experiencing, similar to our hospital, real problems with maintaining adequate staffing, because staff are getting sick with this virus just as surely as the rest of the community. Our larger partners, St. Peter's and Albany Med, have reported upwards of nearly 1,000 employees out on some days in the last week to 10 days. So it's a real struggle for them, as it is for us. With that background, we're all trying to understand how we can make sure that we have the capacity to care for the veterans that present to our hospital for care. Traditionally, we have relied on our community partners as a safety valve to help us with caring for patients that we did not have room for. But in the current circumstance, that's not a guarantee. We've had a number of times in the last week and a half where we've had patients here in need of specialized ICU care that we would normally have transferred to Albany Med or St. Peter's, and both of them had full ICUs and could not accept the transfers. So we worry about that a lot. It hasn't had a big impact yet, but we worry that that is coming. So that leads me to this slide, which is on the screen now, which is projected data that was provided through the VISN and through VACO a couple of days ago as to what might be coming from the Omicron surge, knowing what we know about the transmissibility of the Omicron virus, its prevalence in the community now, and the capacity for vaccines to ameliorate and blunt the degree of illness that people experience if they become infected. You can see there's 3 potential scenarios. I'm not going to go through the specific parameters that they use for each of these scenarios, but you can think of them as bad, worse, and worst from 1 to 3. But they're projecting that the gray line, which is the lowest of the 3 curves you see on that graph, is the best case scenario for what we may have happen over the next several weeks. The dotted red line is the peak hospitalization rate back in April of 2020 when the worst of the last surge happened. And based on these projections, it looks like we might conceivably see 2 or 2.5 times as many hospitalizations as we did back in April of 2020. Bear in mind that this is all projections based on interlocking assumptions, and we really don't know what's coming down the pike. But the possibility is there, and the smart thing to do is to think about it and try to get ready in case it happens. This is all by way of leading up to some of the activity that's been happening in the last couple of days that you may have heard about or seen. As we did back in April of 2020, we are preparing 8 Charlie, the C wing on the 8th floor, for the possibility that we may need to expand our inpatient bed capacity. And FMS is in the process of preparing that wing so that we can use it if needed. We have staffing challenges to try to staff that unit if we open it, and that involves a lot of people adjusting their care schedules and the services they normally provide, and that work is going on in the background now. We have not committed to the idea that we are actually going to open 8 Charlie as acute care beds, but we're preparing for it so that if this projected surge does in fact happen sometime next week, we may say, okay, it's time to do this and open 8 Charlie as acute care beds. As I said before, I hope this doesn't happen. I'm certainly not in any sense guaranteeing that it will happen any more than the snowstorm we're supposed to get on Monday is a guaranteed thing. We've all had the experience of going to bed planning on shoveling out and finding in the morning that there was only an inch of snow on the driveway. And if that happens, I will be very grateful to FMS for making the efforts that they're making now, but I'll also be very grateful that we won't have to open 8 Charlie. So that's kind of the contingency planning that's going on, and we'll go from there. There's a question in the chat box. Are we following new CDC guidance regarding isolation, quarantine in the outpatient setting? The answer to that is coming up on a subsequent slide, and I'm going to let the infection prevention folks answer that guidance because they are way more facile in that than I am.
Okay, thank you, Dr. Howard. So I do want to say that please understand that none of these decisions that we have to make come easy, and that a lot of it is in projection, but I'd rather be prepared than having it hit us in the middle of the night and we can't do anything. That's and that's why we're doing the preparation. And I know it's difficult, but it would be more difficult if at the last hour we find ourselves without staffing, without beds, without supplies. So the preparation and the planning that goes into incident command, like I had said, this doesn't come easy, and it's hard to get our arms around all of this, and it's difficult for many of the decisions that have to be made. But however, they are being made, and we are moving forward. So thank you, Dr. Howard, for providing that. So we're going to go to the next slide.
Director Sean, if I could just add something before we go on to the next slide. I think I mentioned it last week when we're looking at this slide on the screen. I do a lot of the number crunching in terms of tracking COVID in that nature. And while I hear a lot that this variant is milder than the previous variant, I think it's just good for everyone's awareness. We're averaging 15 to 20 COVID positives the past week per day. And our inpatient census is higher now than it was at this point last year. So while it's maybe milder, the increased volume is kind of leading to a more hospitalizations.
Absolutely.
Right, and I think that we can, that's why we have opportunities like this, Sean, to discuss it, to let people know that they're allowed to be upset, they're allowed to, you know, even cry if they have to, but we can't give up. And that's what we're doing right now. We're not giving up, we're making the plans and we're moving forward. Okay, Amy, did you want to talk about some of the hot topics that are going on, and we're going to continue?
Yep. So yeah, like Darlene mentioned, and Dr. Howard, this wave is very different. The one constant is change for all of us. There is still a great concern for the number of nursing staff not being able to work, coupled with schools, you know, going towards remote, and children of staff getting sick as well. We do, like Sean mentioned, see a steady increase in our census, and it does seem that this variant is linked to more disease progression, which is requiring hospitalization of our patients, and that's evident by the admissions of COVID patients. And just yesterday, we started the day with 14 patients, and that was the most we've ever had to date. As of this morning, and this number changes literally hour by hour, we had approximately 20 to 25 nursing staff from various units out of work with COVID and or symptomatic and under investigation. And that may not seem like a lot in the grand scheme of things around nurse staffing levels, but as you can imagine, the staff out sick, our vacancies, staff out of work for other reasons does make meeting patient care needs that much more challenging. So like Dr. Howard mentioned, preparations for 8C are underway. We're also preparing our current units, and we have deferred all elective procedures in the endoscopy unit, operating room, and VIR to redeploy staff to units that we've had to stretch minimal staffing requirements as extra support and helping hands, as well as to upstaff our COVID-19 units across all shifts to ensure adequate nurse to patient ratios as the acuity level of these patients is much higher. And again, we remain sensitive to the PPE fatigue and the effects of PPE fatigue has on our staff. And like Darlene said, the decision to redeploy staff, change tours of staff does not come easy to any of us. And we know that those decisions impact the lives of our staff, and it does weigh heavy on all of us, and it's not lost on us. The same goes for decisions like postponing leave when we have to, or deferring elective services for our veterans. These decisions, although very difficult, you know, they're based on potential threats that may come our way, and they're purposeful in the attempt to preserve the integrity of our mission and the safety of our veterans and our staff, even though it may not feel that way. Currently, our service in nursing doesn't have a pool of nursing resources to fill staffing gaps or to upstaff units on a whim. And as a result of that, we have to plan for any potential threats. And if these projections that Dr. Howard mentioned earlier holds true, we have a rocky road ahead of us for many weeks to come. And I believe in preparing in advance is what any good high reliability organization would do. And it would be a much worse scenario if we saw the potential threats and did nothing. And that would be irresponsible of us. But as always, the acts of altruism that I witnessed by the nursing staff are humbling, to say the least. We appreciate the flexibility during this time. I'm here to support you. I'm also gearing up for fit testing and preparing to work on units, as are the associate chief nurses. And I am a nurse after all, and will do my part to support the efforts. But I'm here to answer any other questions you might have.
Dr. Howard, there's a question for you. Dr. O'Malley asked, we're telling patients with canceled elective procedures, surgeries prior. We did
Yeah,
not.
I've been texting back and forth with her on that while
Okay.
Amy was talking. The answer to people who are reading it similarly is that a COVID related delay is not per se an indication to send somebody to care in the community. And part of that is because our community partners are just as strapped as we are. Having said that, though, if somebody is eligible for community care under the Mission Act, for example, distance, and they had chosen to come here for care, but now we can't provide it, it's certainly appropriate to offer them care in the community. Likewise, if there is a circumstance where delay of care poses a substantial risk to the veteran under the Mission Act, even if they are, live next door to the hospital, if we can't provide timely services and there is a danger to their health because of that, in the judgment of the physician involved, then that person can be referred to the community. Again, with the understanding that the community is just as locked up as we are.
Okay. Well, they are telling us in the chat box how wonderful nurses are, that they rock. So we agree, as with all the employees. So let's go to the next hot topics. So I don't know if we have Marlene Neri or if we have Chris.
So this is Chris Gagnon. I'll quickly go over this. So we're finalizing our guidance for testing staff for exposure and return to work. We should know more about it by the beginning of next week, and we'll be announcing that. Again, we just want to remind our staff that we should consider getting booster shots. It does help prevent severe disease. It should be given 5 months after completion of your Pfizer or Moderna vaccines. If you receive the J&J, it's 2 months after it. And initial vaccines do remain effective, but show reduced protection over time. It's just a reminder. And you can work with your supervisor to schedule your appointment in MS bookings.
Chris, it's Amy. Just to add to the first bullet, supervisors, managers, AO service chiefs should have received an invite for tomorrow morning at 9 o'clock, where we will review the guidance for testing for staff exposure and return to work, with the hopes that we can get everyone with that guidance and an understanding, and to allow for Q&A to happen, and then we'll get it down to the staff. We just want to make sure our managers and supervisors are on board and have a clear understanding before we get that information out to staff.
Thank you. Marlene?
Hi, good afternoon. I wanted to briefly answer the question that Karen asked about new CDC guidance in the outpatient setting. So I want to emphasize that the CDC has not changed their guidance for patients in the inpatient setting. So if you are hospitalized, the isolation has not changed. It is 10 days or 20 days, depending on if you're immunocompromised. So that has not changed whatsoever. In the outpatient setting, I think Dr. Howard mentioned it last week that we're going to be following CDC guidance. So if a veteran has been confirmed positive, day 0 is the first day. So if your symptoms or your positive tests, and then day 1 is the following day. So we're following essentially 6 days of isolation. So the patient must meet 6 days of isolation, and if they have improvement in their symptoms and they're fever-free for 24 hours, they are able to return to their primary care provider or their CBOC. Again, that's a conversation that the PCP or the nursing staff has to have with the patient prior to, informing them that they can come off isolation on essentially the 6th day. If the patient continues to have symptoms, then they should remain on isolation for the full 10 days. And they should be informed that if they are able to come off isolation on the 6th day, that they must be wearing their mask appropriately, covering their nose and mouth when they are leaving their home and entering essentially any area outside of their home. Exposure is a little different, and that's a little bit more complicated. So isolation means you tested positive and you have to remain home for the allotted time. Exposure means that you had an exposure to somebody and you have to follow quarantine. So if you are not vaccinated and you're not up to date on your vaccines, meaning that you did not get your booster as a veteran, then you have to quarantine for at least 5 days. And if you are symptom-free after the total of 6 days, then you can come off quarantine and you still have to wear your mask and monitor for symptoms. They do also recommend that if you don't ever develop symptoms on the 5th day, that you can get a test. And if you are up to date on all your vaccines and you've gotten your booster shot, you don't need to quarantine, but you should just continue to monitor your symptoms. Hopefully that's not too confusing, and you can always reach out to infection control with any questions. I'll then go over the slides quickly. So I just want to reiterate a few key points. COVID-19 enters your body through your eyes, your nose, mouth, and progresses to your lungs. So the same way that it enters is the same way that it's transmitted, so via coughing, sneezing, etc. Ongoing research has shown that the Omicron variant has become more efficient at invading and infecting. It replicates much faster in your respiratory tract and infects at a higher rate. And please note, so I think this is an important fact to remember. Please monitor your symptoms for any mild symptoms, because it presents much quicker. So your symptoms might show 24 to 48 hours, so much sooner than the Delta variant did. And just monitor yourself for any mild symptoms. We continue to emphasize that if you are sick, please stay home, report your illness to your supervisor, who will then reach out to occupational health or infection control, and we will follow up with the employee and offer some guidance. Next slide, Sean. This is a very busy slide, so I'll try to move quickly upon it. So it's important that while you're working, that staff continue to follow all guidelines for mitigating exposure and transmission. So patients must be encouraged, and they need to wear masks during all face-to-face interactions and report symptoms if they have any. Inpatients need to be asked to wear masks if tolerated when any staff member enters a patient room. So if the patient is, in an inpatient ward like ICU, 8B or 7B, and they've been with us, or they're gonna, be admitted, they should be encouraged to put on their mask when a healthcare worker enters their room. All staff need to continue to wear appropriate mask and eye protection. Eyeglasses are not a form of appropriate protection for all patient encounters. All staff need to wear the appropriate mask at all other times, socially distancing during breaks and lunch periods. If you become sick or symptomatic during your tour, please report symptoms immediately to your supervisor, and we will address those concerns at that moment. If you are sick or report an exposure, someone from infection control or occupational health will reach out to you to discuss your specific situation and recommendations for testing and quarantine. Please remember that each case is assessed individually. It's not one, not one size fits all. So just please remember that as well. Next slide, please. So I think Chris is going to do this slide.
Yes. So what should you expect if you're going to be tested? Well, the orders are placed by occupational health. They'll put in the COVID-19 test to be done. When we sample, we're looking for active disease. So if we use an antigen test, the employee is going to be instructed on how to self-collect a swab. If it's a PCR test, the sample needs to be collected by using a nasopharyngeal specimen, and this cannot be self-collected and must be performed by a trained healthcare provider. And this is based on CDC's guidance. Please remember, once we run the test, depending on the type of test available, it can take up to 72 hours, depending on the type of test performed. So we don't always have those answers back right away. Next slide. So I'm not sure if Dr. Carlin's on.
I'm on, Chris.
Okay, I'll let you take these.
Okay, so it's very important to know that we're facing three things at once: Omicron, the flu, some Delta, and the winter. So I say that vaccines and booster, it's like wearing a Kevlar vest. You might get shot, but you probably won't die. So it's really important to do all of those things. Vaccines have remained effective at preventing severe illness, hospitalization, and death. And I was on the regional call this morning, and all the hospitals reported their COVID admissions, their ICU admissions, who was on a ventilator, who had died. And in nearly all cases, the patients with very severe illness, especially ICU, vent, and having died, were ones that were either not vaccinated or maybe got one or two vaccines, but not everything. So it's really very important. Breakthrough Omicron infections can occur. So if you had Delta in the past, you still need to be vaccinated or boosted if you're not, because you can definitely get an Omicron infection after having had Delta. So please protect your patients, yourself, your families, and your coworkers. Get vaccinated, boosted, wear a mask the best that you can tolerate, whether that be N95, in the hospital and outside of the hospital, the best you can tolerate. Social distance, wash your hands, clean and disinfect, and then get tested when needed. Kind of the same old advice, but it's still true and important.
Back to you, Dr. Carlin.
Oh, this too, okay. So symptoms may appear 2 to 14 days after exposure to the virus. And with Omicron, it's kind of pretty fast. With Delta, it was a little slower. Omicron is fast. It still can be 14 days, but it tends to really be, day 1, 2, 3. And you don't have to have all of these symptoms. It can be mild, it can be severe. So scratchy throat, sore throat, fever, chills, fatigue, headache, nausea, vomiting, cough, muscle aches, new loss of taste or smell, even just congestion or a runny nose, diarrhea, shortness of breath, or difficulty breathing. And the VA requires employees to disclose if they or someone they live with are experiencing any of these COVID-related symptoms. And if you are exposed, contact your supervisor or OC Health or Infection Prevention for guidance. And so, of course, in addition to getting vaccinated and boosted, please don't forget to get your flu shot. You don't want to get fluorona, which is a 2-for-1 combination, flu and COVID. And I do want to say whether this is mild or not mild. I don't think we can really say that yet. In South Africa, yes, it was mild, but a lot of those folks were very young people, students, and maybe they would have only gotten mild illness anyway. So I don't know that we can say that. We're having lots of hospitalizations, and in some cases, patients are coming in with COVID or for COVID. So what I mean is they may be coming in with CHF exacerbation, and the COVID symptoms aren't that strong, and yet they're COVID positive. So it's a bit like flu, where you had the flu, not a big deal, and yet you went into heart failure or had an MI or had AFib, and that can be very severe. So we are having lots of hospitalizations. There are still some people in the ICU on vents. So we need to continue to take this very seriously. And with any luck, it will peak in the next couple of months and then hopefully decline.
Thank you, Dr. Carlin.
So Darlene, I'll go through some of the comments we haven't done yet.
Okay.
and questions. Mary Roy says, with the inpatients after the 10-day isolation, is the patient then called previously positive and drop off the daily numbers? Amy and Chris both answered they may be considered clinically resolved, and yes, they drop off the numbers. And Chris said all cases are reviewed after a discussion with ID, and we put a note in. So after the discussion of the patient to be clinically resolved is discussed with the infection prevention and infectious disease team. And then one of the team members will put a note in, so you guys will be notified. And also their banner changes on the top stating clinically resolved. So symptoms can be very mild, consider a low threshold. Rachel Grimm says our primary care teams continue to do an amazing job, doing many different facets of keeping these patients outpatient, keeping track of them very closely with, especially with the amount of patients that they are covering. So great job. Amy says, I can't get over the amount of patients you're allowing in the community and are doing an awesome job. Only possible with strong leadership and staff that remain factual and adapt to the situation. And Rachel, something else you didn't mention was you and Dr. Langdon and the ED team and your team and pharmacy doing all of the remdesivir and monoclonals, all of that tracing. It's above and beyond your normal jobs, and you guys have made a great partnership and really have taken care of the patients to keep them outpatient. Melissa says thank you to the ED and for all the hard work they're doing. ED is a portal of entry, doing it all, MABs, swabs, COVID, and other EDs. And there's been many staff have been very flexible these last 2 years, again, going above and beyond what their normal job duties are. So we appreciate that.
Thanks, Marlene. The one thing that I saw that was from the very beginning was Karen had mentioned that when Tino was talking about visitors to the facility, yes, it is visitors to the CBOCs as well, Karen. So we'll make sure that message gets out for the masking.
And Karen, let us know if your supply is not enough in the CBOCs and we can reach out to logistics for you.
Great comment, Marlene. Okay, are there any other questions?
There's a question, what is being done to increase the isolation capacity of the ED? As said, even the normal complaints have COVID symptoms, more patients are going to have to be isolated.
Is Dr. Pellernon or anyone else can answer that?
Howard, I don't have an answer to that. It's something we should probably consider. Although it gets to be a real problem when you consider the prevalence of this virus within the community. 20% of people testing for the virus in the community right now are positive. And I'm sure that that number is substantially higher in reality because that number doesn't take into account all of the people tested at home and took action on their own to self-isolate, and it doesn't take into account all of the people who just don't get tested either because they're asymptomatic or because they are mildly symptomatic and don't feel like they need to get tested. So the the number in the community is very high. What we do is we insist on universal masking of all patients and providers, and that's by far the best protection we can provide at this point. As Amy points out in the chat box, we do have a private waiting room or a separate waiting room for individuals who come specifically because they have COVID symptoms. I think that Kevin's question had more to do with what about the silent carriers, and universal masking of both patients and providers, as well as eye protection for the providers, is the best protection we have at this point.
Yep, and Mike wrote in the chat box, FMS established the negative pressure waiting area, so thank you, Michael. Dr. Rogera asks, do guidelines for employees who test positive mirror those of veterans? If an employee tests positive, returns to work in 5 days instead of 10, should they have an occupational health test?
Chris, you want to
I
jump
think
in
Chris
there?
wants to take this one.
I'll take one for the team. We're in the process of revising our guidance for our employees. If you are a veteran and you are an employee, you need to follow our employee guidance. And right now it has not changed. When it does change, we're going to make everybody aware of it next week. And there will be some testing that will be done to allow staff to return to work sooner. I'm not going to go into any details until it's all finalized.
Thanks, Chris.
So I think that's the end of the questions, and I'm going to end with the way we started. These are difficult challenges that we have. You all recognize that, and you're not being applauded outside your window, and there's not a lot of cars driving by beeping and thanking you. But know that you are supported by the executive team, and that if there's an opportunity to do more for you, please let us know. We have a very strong partnership with the union that we're keeping updated weekly or more often if they need to. And so we are giving them, information prior to it going out. They are here for you. We are here for you. I thank you, and we'll set up another opportunity to have another town hall, because as many have said this, things change very, very, very quickly. So I ask that you remember when I started off the conference, I talked about the struggling and what has brought me back to where I need to be, and that's the mission of the organization. Remembering why we come to work every day, and remembering why we're here. And that gives me pride in what I do. So thank you. And I'll talk to many of you throughout the day. And I know that we're all going on to our next meeting. So bye, everyone.